and I'm in hall 2. I request Sirisha to start the proceedings without any delay. Sirisha, you're muted. Sirisha, you need to unmute.
Yes, ma'am. Sorry. Good morning, everyone.
Good morning.
Our session today, which is the three-paper session. For this, I invite our chairpersons, Dr. K. Lakshmi Prasad, sir, who is a senior consultant dermatologist, Aditya Skin Clinic, Hyderabad, and Dr. Bhanuja Rani, ma'am, who is an assistant professor, Department of Biochemistry, Gandhi, and also consultant and founder of GVK Skin Clinics. Without any further delay, I hand over the further proceedings to the chairpersons.
Good morning, everyone. Welcome to TSCUTICON. Now we are going to have free papers. The first presenter is Shahida Begum. I invited Dr. Shahida Begum. Her topic is Xanthoma disseminatum, a rare variant of xanthomatosis with genital involvement. Dr. Shahida Begum.
Good morning, everyone. As said, my topic is Xanthoma disseminatum with genital involvement, which is rare.
Please share your screen, ma'am.
Yeah, sure.
Full screen, please.
So is it full screen, sir?
Yeah, it's visible. You have 7 minutes and the time starts now.
So as the topic known for everyone, it's Xanthoma disseminatum, a rare variant of xanthomatosis with genital involvement. So in the introduction, Xanthoma disseminatum is a rare, chronic, benign, normolipemic xanthomatosis characterized by discrete but scattered small yellowish, brown or reddish papules and nodules, some of which become pedunculated. The disease generally affects young males. Lesion chiefly develops on the flexure, face, oral mucosa, oropharynx, larynx, and at times the conjunctiva. When large, they may produce dysphagia, hoarseness of voice, and dyspnea. Central nervous system involvement of the hypothalamus and pituitary stalk result in the diabetes insipidus in 1/3 of the patients. Most of the forms do not require any early interventions. Lesions in the central critical anatomical locations may result in morbidity and mortality. Although many conservative treatments are unsatisfactory, active intervention may still be warranted for the disfiguring type to prevent the permanent functional impairments or for the cosmetic reasons. Here I report a case where a 30-year-old married female presented to the skin OPD with the complaints of multiple asymptomatic elevated lesions on the face, back, abdomen, buttocks, genitalia since 1 year. Initially, a few skin-colored lesions appeared on the neck, which gradually increased and changed into the reddish-brown in color to attain the present lesion. There is no history of bleeding, redness, ulceration over the lesion. There was no family history or personal history of atopy. No comorbidities were documented. There was no history of blurring of the vision or dysphonia. On clinical examination, there was bilaterally symmetrical, multiple dome-shaped papules of reddish-brown color on the face, perineal area, and similar regions were also seen on the external genitalia, back, abdomen, and there was generalized xerosis seen all over the body. Oral mucosa, hair, nail were normal. Prior to approaching us, the patient has went to some of the hospital with the above complaints and was diagnosed with the genital MC and were treated with the topical trichloroacetic acid, potassium hydroxide, and radiofrequency on the few lesions over the genitalia. Systemic examination, including the oropharyngeal, ophthalmic, and otolaryngal workup, Liver in the renal function test, the lipogram, which included the serum triglycerides, total cholesterols, and high density lipoprotein cholesterol, VLDL, very low density lipoproteins, hemogram, ESR, complete urine examination, Montague's test, serum calcium levels, all were within the normal limits. Serological tests for HIV 1 and 2, HBs, AG, VDRL, HCV, all were non-reactive. To roll out the molluscum contagiosum, extirpation of one of the lesions on the back was done, but there was no MC body seen. These are the photographs which is depicting the same. With the left side of the photograph, I have done the MC extirpation. In order to rule out the MC body, I have done extirpation of one of the lesions. You can see the bleeding in spite of the MC body. Here the lesions are present on the face, the lateral aspect, and on the anterior aspect. This is the rare involvement of the genitalia. The lesions which are dome-shaped, skin color to slightly reddish brown, seen on the genitalia. In the differential diagnosis, Xanthoma disseminatum, molluscum contagiosum, sarcoidosis, calcinosis cutis, and histioid leprosy was considered. The histopathology was done and sent for histopathological examination, the biopsy, which revealed thin, flattened epidermis with loss of retrogenous, dense reticular dermis with widely proliferating vacuolated adipocytes, which was interspersed with the numerous lymphocytes and macrophages. No cytological atypia was seen. Histopathology was suggestive of Xanthoma disseminatum. Based on the characteristic clinical feature and histopathology, a diagnosis of Xanthoma disseminatum was made. Right side, the image shows the same histopathology image. Discussion. Xanthoma, which is in Greek a yellow tumor, is an uncommon presentation of a generalized or localized disturbance of the lipid metabolism and may be associated with an increased risk of arteriosclerotic vascular disease and occasionally with pancreatitis. Xanthoma disseminatum is a rare non-familial disease characterized by proliferation of the histiocytic cells in which the lipid deposition is the secondary event. It was first described in 1938 by Montgomery and Osterberg. The disease predominantly affects male children, young adults, but can occur at any age in either of the sexes. 50% of the lesion appear before the age of 25. It may occur anywhere on the body, including the scalp, face, trunk, and extremities. Its pathogenesis remain unclear. The neoplastic but pathological non-histiocytic cell proliferation reaction pattern of the macrophage or monocyte origin is perhaps triggered by some superantigens. The accumulation of the lipids within the histiocytes is perhaps the secondary to increase uptake, synthesis, or decrease efflux of the lipids. Depending upon its evolution and progresses, it is grouped in three forms: a self-healing form with spontaneous resolution, a persistent form, which is the commonest one in which the lesion may never resolve, and a very rare progressive form with organ dysfunction and central nervous involvement. It is a self-limited disease but may be locally destructive and may persist for years. We consider our patient to be affected with progressive form. Patients with Xanthoma disseminator are usually now normal lipemia. Lipid deposition in the skin being secondary to the histiocytic proliferation. And this has led some authors to classify XD as a normal lipemic xanthomatosis.
You are left with 1 minute, please.
Okay. Treatment. The skin lesion of the Xanthoma disseminatum are disfiguring and patients often request treatment for cosmetic reasons only. A CO2 laser has been used with good results. Other forms of surgical removal, excision, dermabrasion, and electrocoagulation has been used with moderate effect. Localized conjunctival involvement can be treated with surgery. Surgery has also been used in CNS disease, but recurrence may occur and not all CNS lesions are amenable for resection. Systemic involvement with lung, liver, and CNS requires the active treatment with glucocorticoids, chlorambucil, azathioprine, cyclophosphamide, which are effective in some patients with cutaneous diseases. And the conclusion is, here we present a case of XD with genital involvement, which is rarely reported in the literature. A case presented by us had cutaneous involvement, but with rare occurrence over the genitalia and no mucosal involvement. Thank you so much.
Thank you, Dr. Shahida.
Welcome.
Can we invite the next presenter, please?
Yeah. The next presenter is Dr. V.K. Shankar. He is presenting a paper, Silvery Gray Hair, a case report on Griscelli syndrome. Dr. V.K. Shankar, please.
Good morning, everyone. Good morning, everyone. I am Dr. V.K. Shankar. I am going to present silvery gray hair, a case report of Griscelli syndrome type 2. Coming to Griscelli, it is a rare autosomal recessive multisystem disorder of pigmented dilution of skin, silvery gray hair, variable immunodeficiency, neurological impairment, and abnormal accumulation of melanosomes in melanocytes. It has three types, type 1, type 2, type 3. Among them, type 3 is characterized by involvement of only skin and hair, and it has good prognosis, as opposed to type 1, type 2, where diagnosis and treatment plays a crucial role in patient survival. Coming to case report, a 4-year-old female child came to the pediatric department with complaints of hematuria, facial puffiness, fever, and pedal edema since 15 days. History of recurrent pyogenic skin infections noted in the child since 2 years of age. She was reported to hematology department in view of silvery gray hair over scalp. There is no history of jaundice, vomiting, abdominal pain, photosensitivity, and convulsions in the child. She was born out of consanguineous marriage with no antenatal or perinatal period. Her birth weight was normal. She had no neonatal intensive care admissions. Her physical development was normal. Her elder sibling, aged 7 years, female, also had similar complaints of recurrent upper respiratory tract and pyogenic skin infections since 3 years of age. She also had silvery gray hair over scalp. Coming to examination, on cutaneous examination, patient had silvery gray hair over scalp with eyebrows, eyelashes, and other body hair noted normal. Skin pigmentation noted normal. Teeth and nails appeared normal. Coming to systemic examination, GI system, there was no hepatosplenomegaly. Central nervous system, respiratory, and cardiac system examination are within normal limits. Ophthalmological examination did not reveal any abnormality. This is a picture of the child showing silvery gray hair over the scalp with eyebrows, eyelashes, other body hair noted normal pigmentation. Skin pigmentation noted normal. Coming to investigations, hematological profile, child HB 6.8 grams, WBC count 5100, platelet count 35,000. On peripheral smear, RBC shows anisocytosis, microcytosis, hypochromic anemia, platelets, normal morphology with thrombocytopenia seen. WBC, normal morphology, and no intracytoplasmic granules noted in smear. Liver function test normal, renal function test noted normal, serum protein, serum albumin noted normal. On ultrasound abdomen, no hepatosplenomegaly noted. This is a light microscope picture of hair showing uneven clusters of large aggregated melanin pigment accumulated mainly in the medullary area of shaft. Based on the above features, my differential diagnosis are celiac syndrome and proteinuria malnutrition. We initially thought of proteinuria malnutrition because child is from economically poor backgrounds. We initially thought malnutrition may be the cause of the hair changes, but on further investigating, we found that serum proteins and serum albumin was normal, and other parameters like height for age, weight for age, everything is normal. So we are excluded proteinuria malnutrition. Next, coming to other differential celiac syndrome. We ruled out celiac syndrome because presence of large irregular melanin clumps with no intracytoplasmic granules in leukocyte favored Griscelli syndrome in our case. Discussion. In this case, based on consanguineous marriage in history, absence of a neurological involvement with silvery gray hair, recurrent pyogenic infections, anemia, thrombocytopenia, presence of melanin clumps, a provisional diagnosis of Griscelli type 2 made. Though there is no hepatosplenomegaly, diagnosis of Griscelli type 2 was made because there are chances of onset of hemophagocytic syndrome at later age with milder phenotype associated with missense mutations in RAP27 gene. Coming to Griscelli, on basis of molecular genetics as well as clinical findings, it was separated into 3 clinical entities, type 1, type 2, type 3. Griscelli type 1 associated with MIO5 gene mutations characterized by silvery gray hair and fair skin, neurological involvement. Griscelli type 2 associated with RAP27 gene characterized by silvery gray hair and fair skin, immunological defects. Griscelli type 3 associated with MLPH gene mutation characterized by silvery gray hair, fair skin. Among them, type 2 is most common, with type 3 being least common. All genetic alterations associated with Griscelli syndrome result in defective transport of melanosomes and consequently abnormal accumulation of melanosomes in melanocytes. Presence of grayish hair is hallmark of all 3 types of Griscelli patients. In Griscelli type 2, particularly RAP27A protein is involved. It is a GT base mainly required for organelle movement and transfer, essential for T and natural killer lymphocyte cytotonic gland release and target cell death. It interacts with MLPH protein to form protein complex necessary for capture and local transport of melanosome to melanocyte. In our case, we've seen pigmented dilution of hair because of defective transport of melanosomes and recurrent pyogenic skin infection because of absent of T and natural killer cytotoxic activity. Severe immune disorder characterized by hemophagocytic syndrome with fatal outcome had reported in cases of Griscelli type 2 in literature, but in our case, we have not seen any signs or hemophagocytic syndrome. There are chances of occurrence of hemophagocytic syndrome later age in this case. Genetic studies not done in this case because of financial constraints. Genetic studies would have filed further to confirm diagnosis and to offer prenatal counseling. Making a correct and early diagnosis very important in this case, particularly Griscelli type 2, because it improves chance of survival. Treatment is hematopoietic stem cell transplantation for Griscelli type 2 syndrome. It reverses all immunological, hematological alterations, but it will not reverse any pigmentary changes of skin and hair. In type 1, only conservative treatment, and type 3, no treatment is required. These are my references. Thank you.
Thank you, Dr. Shankar. Next presenter is Dr. Praveen Kumar. Dr. Bhanjarani to introduce the speaker, please.
Good morning, sir. Myself, Dr. Praveen from Common Medical College, sir, Narkitpalli. Today's my presentation is toenail changes in diabetics. Hello.
Please carry on.
Okay, sir. Introduction. Nail, though considered dead structures, have attracted attention since years ago. They occupy a very small area of body, yet play a significant role. Nails are made of keratin.
Dr. Praveen, can you share your screen?
Screen share. Screen share. Is it okay, ma'am?
Yes, it's visible. Make it
Okay,
full screen.
Thank you, ma'am. Nails, though considered dead structures, have attracted attention since years ago. They occupy a very small area of the body, yet play a significant role. Nails are made of keratin and grow lifelong, which protect the nail bed. The nail matrix is living tissue which produces nails, which is visible as present as white crescent at the base of the nail. Under normal conditions, the mean growth rate of fingernails is 3 mm per month, and of toenails is 1 mm per month. Nail increases sensory perception of finger pads and contribute to the temperature regulation. Fingers take about 4 to 6 months for complete growth, and toenails take about approximately double the time. Nail growth rate can be influenced by several factors, including age, local and/or systemic diseases and medications. Diabetes is a metabolic disorder caused by abnormal release of sensitivity to the insulin hormone with loss of blood glucose control. Uncontrolled diabetes can have Uncontrolled diabetes can have devastating effect on many organ systems, including cardiovascular, neurological, ocular, renal, and with its impact on skin, hair, and nails. Have their own problems in the form of various diseases, but also acts as a screen for different systemic illnesses like diabetes, various physiological as well as disease-associated changes and disorders seen in the diabetic nail. Many of these are extremely painful, affecting stability, ambulation, and other functions like tactile sensation and protective functions. But being such significant part of the body, the incidence of the disease of nail claims a considerable portion of total dermatological disorder in modern medical sciences. The prevention and management of these conditions require periodic cutting of nails and appropriate medical care. No physical examination in the dermatology is complete without the study of nails, because most of the nails is a mirror image of underlying systemic diseases. In spite of such vital role, the nail still remains understudied and underutilized. Hence, the study was undertaken. Periangular erythema and telangiectasia are seen in the nail folds as an early finding of diabetes. Thickening of skin of proximal nail folds can be seen in up to one-fourth of the diabetics. Thickening of toe nails and even onychogryphosis are due to the microangiopathic changes in the chronic diabetes. Coming to pathogenesis, capillary abnormality due to the alteration in the function of endothelial cells, higher plasma viscosity due to erythrocyte rigidity and aggregation, neuropathy leading to altered arterial contractile functions, impaired microvascular walls of arterioles, venules, and capillaries due to hyperglycemia, removal of glycation products accumulated in the structural proteins of microvasculature by the specific macrophages. Due to these pathogenic mechanisms, vessel walls thicken and loses its elasticity. Increased glycation of hemoglobin, which leads to hypoxia, which is one of the prerequisites for microangiopathy. Coming to patients and methods, during the 5 months period that includes from October 2019 to February 2020, sample size of 40 patients with diabetes mellitus attending dermatology OPD and outpatients and inpatients in other departments in the KIMS hospital were screened for any toenail changes. Data regarding demographic, social and clinical history were collected and toenail care habits were recorded. Thorough observation of feet and nails were performed. Change in foot anatomy, callosity, and other deformities were recorded. Routine investigations like random blood sugar, complete hemogram, urine analysis were done. Fungal nail changes were noted. Fungal tests like direct microscopy of 40% KOH preparations were done. Coming to inclusion criteria, patients of any age and both sexes with diabetes alone and diabetes with other systemic disorders are included. Exclusion criteria, patients with the diagnosis of diabetes mellitus for less than 6 months and are unable to provide information due to comorbidities or critical conditions or refusing to participate were excluded from the study. Coming to observation and results, out of the 40 patients, 4 patients are between the age of 40 to 50, of which 3 are males and 1 is female. And between the age of 51 to 60 years, 8 patients were observed, and of which 6 are male and 2 are female. Above 61 years, 28 patients were there, of which 20 are male and 8 are female. Coming to spectrum of nail changes, subungual hyperkeratosis were noted in 10%, onychomycosis in 6%, toenail ingrowing toenail was in 4 patients, paronychian 3 patients, onychohysis in 3 patients, pitting in psoriasis with diabetes mellitus in 3 patients, teres nail in liver disease and diabetes mellitus in 3 patients, koilonychia with anemia and diabetes mellitus in 3 patients, paronychian. Koilonychia in 2 patients, onychorexis in 2 patients, onychomadasis in 2 patients, and onycholysis in 2 patients, dorsal pterygium in 1 patient, and onychogryphosis in 1 patient. These are my clinical images. First image is Bruce lines. Second image is koilonychia with anemia. And these first image is of acute paronychia with ingrowing toenail. Second image is of chronic paronychia. Third one is of pincer nail deformity. And these are the images of 20 nail dystrophy. These are the images of onycholysis. First two has only onycholysis. Third one has onycholysis with subungual hyperkeratosis due to onychomycosis. This is the image of onychomadasis, which was seen in first and second toe. This is the image of onychogryphosis. First one is onychogryphosis due to the subcutaneous fungal infection.
You are left with
and,
1 minute, please.
Second image is of onychogryphosis with the yellowish discoloration. These are the images of onychohysis and onychodystrophy. These are the images of subungual hematoma with sphincter hemorrhage and nail pterygium and subungual warts. These are the images of teres nails with liver failure in diabetes mellitus and pitting in psoriasis. Conclusion: physicians who care for diabetes patients should not ignore nail changes due to higher prevalence of toenail changes in diabetes. Nail changes are useful in diagnosis of systemic diseases such as clubbing of finger and in pulmonary or cardiovascular disorders, which are seen before other signs of systemic disorders become clinically evident. And toenail changes may indicate the need for general care measures, appropriate footwear, foot deformity correction, and antifungal treatment. Patients and their caregivers should be educated about nail care and proper implementation. These are my references. Thank you.
Thank you, Dr. Praveen.
Okay.
Yeah. Can I call the next speaker, please?
Sir, can I start?
Yes, sir. Please invite the next speaker.
Yeah. Next speaker is Dr. Sneha Somareddy. Her paper is study of clinico-pathological and dermoscopic features of the rare dermatosis, epidermodysplasia verruciformis. Please.
Good morning, everybody. Today I'm going to present a study of clinicopathological and dermoscopic features of rare dermatosis, epidermodysplasia verruciformis. EDV is a rare genodermatosis characterized by flat verrucous lesions and pityriasis versicolor-like lesions, mainly seen on the face and sun-exposed extremities, appearing in childhood or adolescence. Red macules and seborrheic keratosis-like lesions are also seen. More than 100 HPV subtypes known to cause EDV, of which subtypes 5 and 8 are responsible for more than 90% of malignancies in EDV. The pathogenesis is defects in cell-mediated immunity and humoral immunity, which increases the susceptibility to HPV infections. There are two forms, inherited and acquired form. Inherited form is mainly because of EVER1 and EVER2 mutations, mainly inherited as autosomal recessive, and XLR and autosomal dominant sporadic forms are also seen. Acquired form is mainly because of immunodeficiency that may be in HIV and organ transplant patients. High risk of developing cutaneous malignancies early in life, mainly in 3rd to 5th decades of life, with a latency of 10 to 30 years from the initiation of the lesions can be seen. Pre-malignant and malignant lesions like actinic keratosis, Bowen's disease, and squamous cell carcinoma are common. Other NMSs can also be seen. Early recognition and treatment of pre-malignant lesions is necessary to prevent progression to malignancies. Aims and objectives to describe various clinical presentations, histopathological features and dermoscopic features of various lesions in 9 patients of EDV who presented to outpatient department over a period of 2 years. Punch biopsies from suspected lesions subjected to histopathological examination. Diagnosis of EDV was reached based on the histopathological features. Clinical pictures were taken and dermoscopic characteristics of various lesions were studied using handheld dermoscope with 15x magnification. HIV serology and routine investigations were done in all patients and CD4 counts done in only HIV patients. In case series, we noted down the age and sex of the patient, and in clinical features, we noted down the duration and the type of lesions. Then pseudocobner phenomenon was present or not, and if lymphadenopathy was present or not, hepatosplenomegaly was present or not. And then family history was noted and associations were noted like HIV or any immunodeficiency, and histopathology and dermoscopy were done. Briefly, clinical features in most patients was pityriasis versicolor-like discrete or coalescing macules, papules, and plaques on the sun-exposed areas as shown in the photographs. And in patient 3, she was a female and she presented with these lesions since 30 years. She was a 45-year-old female and she had brown-black crust over the forehead with underlying painful ulcers as shown in white arrows here, and few seborrheic keratosis-like lesions around the eyes as shown here, and hypopigmented plaques with central violaceous pigmentation were seen all over the body. Histopathological features on lower magnification were shown to be mild to moderate hyperkeratosis, mild to moderate acanthosis, and mild or no papillomatosis with few vacuolated cells seen in upper spinous layer. Inflammatory infiltrate was sparse and usually perivascular and superficial band-like, as seen here. Superficial superficial band-like infiltrate and perivascular infiltrate, and here we can see vacuolated cells. Then in higher magnification, there was hypergranulosis and large keratinocytes in the upper spinous layer showing pale or blue staining cytoplasm with large central nucleus. There were also perinuclear halos as shown in the black star and blue-gray staining cytoplasm. Histopathological features of the forehead ulcer in patient 3 on lower magnification show discontinuation of the epidermis, breach in the basement membrane, infiltration of epidermis with numerous cells and numerous keratin pearls as shown in black stars. Sorry. And in higher magnification, numerous dyskeratotic cells were present with pleomorphic nuclei and vesicular, and they looked vesicular, suggestive of squamous cell carcinoma. Dermoscopic features of most of the cases showed cloud-like white areas, irregular, ill-defined borders, dotted vessels, and background erythema was present or not present, like in this picture, this and this picture. And the pigment network was hazy if present, and scaling if present was white in color. We can see here a pigment network In this picture, a hazy pigment network, and this also. But here the pigment network is not seen. Dermoscopic features of forehead lesion of the patient 3 showed brown-black crust, atypical pigment network, white structureless areas, perifollicular circles, as shown in this white black arrow. And there were also serpentine vessels as seen here. And there was also background erythema.
1 minute, please.
This was suggestive of SCC. Results: 5 out of 9 patients were children. Family history was present in 3 patients. HIV positive were 3 patients. CD4 count was less than 150 cells per mm cube in all HIV patients. Pseudocobner was phenomenon was present in 3 patients, and pityriasis versicolor-like lesions were the most common seen in sun-exposed areas. Malignant changes seen in 1 adult patient in 5th decade in SCC. All HIV negative patients with EDV had onset in childhood, suggesting a genetic component. HP findings were mainly mild acanthosis, moderate hyperkeratosis, large keratinocytes in upper spinous layer, and large nucleus and pale staining as bluish cytoplasm with vacuolation. Dermoscopic features were, as already told, were cloud-like white areas with irregular or ill-defined outline with or without erythema, dotted vessels, pigment network, and scaling if present was mild and white in color. Brown-black crust, atypical pigment network, white structureless areas, perifollicular circles, irregular serpentine vessels without surrounding erythema was seen in SCC in one case. There were 3 reports previously, of which 2 were hypopigmented lesions of EDV, which showed whitish area with mild scaly surface. These were consistent with my study. And non-uniform pigmentation with per lesion hyperpigmentation was most common dermoscopic feature in a study of hypopigmented pityriasis versicolor in one study, differentiating it from the said dermoscopic features. Conclusion: knowledge about varying presentation of EDV is necessary for diagnosis, which is aided by histopathology and the dermoscopy as facilities for mutation analysis for defective genes of immune system, and nucleic acid detection methods of HPV in lesions are not widely available. Dermoscopy helps in quick assessment of the lesion during follow-up visits and early diagnosis of pre-malignant and malignant lesions. Though treatment modalities are unsatisfactory, patients should be counseled regarding inheritance patterns and need for sun protection. Our study is by far the biggest case series to describe dermoscopic features of EDV along with clinical etiological and pathological features. These are my references. Thank you.
Thank you, Dr. Sneha. May I call upon the next speaker, please?
Yes, sir.
Next speaker is Dr. Akhila. Her topic is Zinsser-Cole-Engman syndrome, a rare case of congenital poikiloderma syndrome. Dr. Akhila, please.
Rare case Zinsser-Cole-Engman syndrome, which is a rare case of congenital poikiloderma. This is also known as dyskeratosis congenita. It is a rare genodermatosis which is first described by Zinsser in 1906. Later, Engman and Cole et al. Reported other cases in detail, hence it is known as Zinsser-Cole-Engman syndrome. It is caused by mutation in gene known as DKC1 located on chromosome X. This gene encodes a protein known as discarin, and this discarin protein is involved in RNA biosynthesis and ribosomal subunit assembly. Deficiencies in discarin likely to affect tissues with high cell turnover, mainly bone marrow and skin. It has X-linked recessive inheritance, which has a prevalence of 1 per 10 lakh. It is mainly characterized by a triad of nail dystrophy, oral leukoplakia, and reticular pigmentation. Case history: a 17-year-old male presented with yellowish-brown discoloration and roughening of nails of both hands since 4 years. He had also history of dark colored lesions over sides and anterior aspect of neck since 2 years. Whitish lesions in oral cavity since 1 year. History of loss of nails of both toes and excessive tear formation. There is no history of photosensitivity or dysphasia. He had a similar history in his first degree maternal uncle, and there is no history of consanguinity in his parents, and no similar complaints are seen in his siblings. On general examination, patient is conscious, coherent, and cooperative. Pallor is present. On systemic examination, all the vitals are within the normal limits. On cutaneous examination, there is reticular hyperpigmentation seen over anterior and lateral aspects of the neck with hyperlinearity of the palms and soles. On examining the nails, there is anonychia of nails of the toes, ridging and thinning of nails, and few absent nails of hands. On examining the eye, epiphora is present, hair is normal. On examining the oral cavity, whitish plaques are seen on buccal mucosa and soft palate, and there are no dental anomalies. With this clinical triad of nail dystrophy, reticular pigmentation, and leukoplakia, I support the diagnosis of dyskeratosis congenita. Dyskeratosis congenita is a clinical diagnosis. On complete blood picture, hemoglobin is 6.4 grams, RBC is 2.1 millions, platelet count is 50,000, WBC count is 1,900, reticulocyte count is 1.98%. On examining the peripheral smear, there is microcytic hypochronic anemia. Both the WBC and platelet counts are decreased. Other investigations like renal function test, liver function test, complete urine examination, all are within normal limits. On doing the skin biopsy, there is epidermal atrophy with increased with the liquefactive degeneration of the basal layer and increased melanophases in the papillary dermis with telangiectasia in the dermal blood vessels. On doing ultrasound abdomen and chest X-ray, they are normal. The patient is given symptomatic treatment with topical retinoids for leukoplakia and is referred to ophthalmologist for management of epiphora. And patient is also counseled about the prognosis and advised to come for regular follow-ups to identify any complications at earliest. And he also, the patient is also counseled for genetic testing, but he is not ready for that because of his financial issues. Discussion. Dyskeratosis congenita is an uncommon hereditary disease and it has 3 patterns of inheritance: X-linked recessive, autosomal dominant, and autosomal recessive. Most common is X-linked recessive. Meaning of dyskeratosis is irreversible degeneration of skin tissue, and congenita means inborn. It is characterized by triad of nail dystrophy, oral leukoplakia, and reticular pigmentation. Nail dystrophy usually begins with ridging, longitudinal splitting, and progresses to small rudimentary or absent nails. And the second symptom of mucosal leukoplakia is pathognomic, which involves buccal mucosa, tongue, and oropharynx. Persistent erosions and leukoplakic areas increases the risk of malignant transformation, and hence the patient requires frequent monitoring. And the pigmentation is usually hyper or hypo, and the pattern may be motile or reticular. Poikilodermatous changes like atrophy, telangiectasia are commonly seen involving the sun-exposed areas like neck, face, and upper trunk. Other features includes bone marrow failure, predisposition to malignancy, and fatal pulmonary complications. Bone marrow failure leads to aplastic anemia, which is a main reason for opportunistic infections in about 70% patients, and it is a major cause of death. And second major cause of death is malignancy, usually occurs on the leukoplakic areas of the mucosa. Pulmonary complications like fibrosis, involvement of skeletal, gastrointestinal, and genitourinary systems is also seen. It should be differentiated from other poikilodermatous syndromes like Rothmund-Thompson syndrome, which can be differentiated by stunted growth, and Kindler syndrome, where there will be trauma-induced blistering. Conclusion: it is a rare cause of poikiloderma where there is no definitive treatment. Proper history, clinical examination, relevant blood investigations will suffice to diagnose this condition. As there is no definitive treatment, it is important to diagnose the disease at the earliest so that we can reduce the risk of malignancies and serious complications like bone marrow failure, oral, dental, and ocular sequelae. So the patient's early treatment and constant monitoring will help us increase the life expectancy of the patient. Carrier testing of relatives should be considered due to variable penetrance and presentation with complications. Molecular diagnosis also enables DNA-based first trimester prenatal or pre-implantation genetic testing for affected families. Thank you.
Next, it's a case report by Dr. B. Sravya.
Dr. Shravya?
Next case report by Dr. Shravya.
Shravya, you're not audible.
Ma'am, am I audible?
Yes, now you're audible. Please go ahead.
I'm Dr. Shravya, final year postgraduate from KIMS Narketpalli. I'm going to present a case of a rodent ulcer burrowing deeper, a case report. Introduction. Basosquamous cell carcinoma is a rare variant of basal cell carcinoma with an incidence of less than 2% of all non-melanoma skin cancers. It is seen predominantly in old Caucasian males and most commonly located in head and neck area or in other sun-exposed areas. It has areas of dominant to basal cell carcinoma and squamous cell carcinoma with a transition zone between them, suggesting differentiation of one tumor into another. Typical basosquamous cell carcinoma is a subset of cutaneous cancers that has an increased risk of metastasis to the patient due to its aggressive behavior. A 60-year-old male patient presented with painful ulceration over right side of the forehead since 20 years, which was gradually increasing in size. Cutaneous examination revealed a solitary well-defined ulcer of size 9 by 10 centimeter with hyperpigmented rolled out edges with floor showing areas of necrosis intermingled with hemorrhagic areas and pale granulation tissue with indurated base located over right forehead involving eyebrow and upper eyelid extending onto scalp. This image, it shows the ulcer of 9 by 10 centimeters with hyperpigmented borders and rolled out edges and pale granulation tissue. After 7 to 8 months, the patient started the ulcer started increasing in size with necrotic areas, a few necrotic areas and hemorrhagic areas, and there was pale granulation tissue, and the ulcer started eyelid covering the eye, and even it also started increasing in size, extending onto the scalp. On ocular examination, it revealed a mass protruding into upper eyelid with chemosis and congestion with severe visual impairment. In view of the locally aggressive nature of the lesion, age of the patient with no lymph node involvement, a provisional diagnosis of basal cell carcinoma was assumed and H biopsy was performed. On histopathology, the section showed tissue bit lined by stratified squamous epithelium and dermis with tumor cells arranged in lobules and in nests. These cells showed peripheral palisading with round to oval nucleus and vesicular chromatin and scant cytoplasm. Few of the nests show central keratinization. Large areas of necrosis also seen. Based on these features, it was suggestive of basosquamous carcinoma. This image is in magnification, which showed stratified squamous epithelium with the dermis showing infiltration with tumor cells, which are arranged in nests and lobules. And in high power magnification, there was a inflammatory infiltrate with tumor cells arranged in nests with central keratinization in these two places. And the next image, it shows nest, inflammatory infiltrate with nests of the tumor cells, where there is peripheral palisading. After which contrast enhanced CT scan was performed, which showed irregular enhancing soft tissue thickening, which is involving right frontal and lateral aspect of the right orbit. And both medially and laterally, the lesion eroded outer table of the right frontal sinus. Inferiorly, there was erosion of the roof of right orbit with infiltration of intraconal and extraconal fat of right orbit. And there was also infiltration of right lacrimal gland, and muscular tendinous junction, right lateral rectus was also involved. All these features are suggestive of malignant neoplastic lesion. The first image, it shows erosion of the both inner and outer cortex of the frontal bone on the right side. And the second image, it shows the dura is also involved, which was thickened and hyper enhancing, which is suggestive of dural invasion on the right side of the frontal bone. After which there was complete resection with tumor-free margins was advised for the patient. Coming to discussion, basosquamous carcinoma is an aggressive epithelial neoplasm with a propensity for local recurrence and potential for distant metastatic spread. Its behavior differs substantially from basal cell carcinoma. Though basosquamous carcinoma is a rare variant, it has significantly higher metastatic potential. Conclusion, this case highlights the rare and aggressive presentation of basal cell carcinoma with involvement of dura mater and infiltration of orbit affecting vision. An early diagnosis of basosquamous cell carcinoma with regular follow-up is important due to the particularly aggressive nature of the tumor, the increased likelihood of the recurrence, and the potential for metastasis. These are my references. Thank you.
Thank you. Next speaker is Dr. Pravallika.
Dr. Pravalika, you there?
Good morning.
Yes, start.
Presenting the rare case of leukemia cutis. Leukemia cutis is the infiltration of neoplastic leukocytes or the precursors into the epidermis, dermis, or the subcutis, resulting in clinically identifiable cutaneous lesions. This diagnosis of leukemia cutis, it gives a clue that it has a broad prognosis, and even there are additional signs of extramedullary involvement. And by this, we can change the appropriate treatment. Here, a 50-year-old man, he presented with asymptomatic multiple red raised lesions all over the body of 4 months duration. His general examination, it revealed pallor and lymphadenopathy. On cutaneous examination, we found multiple erythematous papules or nodules of sizes ranging from 1 to 2 centimeters, and they involved face, trunk, and extremities.
Some disturbance in the audio,
This is a
please.
figure showing multiple nodules and papules all over. So, these papules and nodules were soft form in consistency, and they were not non-tender. And oral cavity showed hypertrophy of the gums. When next we did ultrasound, it showed hepatosplenomegaly, and in hemogram it showed severe leukocytosis and thrombocytopenia. The peripheral smear it showed elevated leukocyte count. Monocytes, they accounted for 20% of the differential count, and megakaryocytes and platelets were grossly decreased. This is the oral cavity showing this hypertrophy of the gums. On biopsy, it was taken from a nodule on the back of the trunk, and it showed normal epidermis, and the dermis was filled with uniform atypical cells, and these were arranged in nodules and at places in single files. And these cells, they showed a high nuclear cytoplasmic ratio, which indicated it as a live tumor. This is the histopathology showing the normal epidermis, and the dermis is infiltrated with atypical cells. With the bone marrow and peripheral smear findings, the patient was diagnosed as a case of acute myeloid leukemia as per the French, American, British classification. Then the patient was referred to oncology department, and he was given chemotherapy cycles with injection azacitidine, following which there was a complete resolution of the lesions. Discussion in general, the international incidence of leukemia cutis is between 2.9 and 3.7 centimeter for acute myeloid leukemia seen in the case. However, 7% of the cases they present as ileukemic leukemia cutis, and out of this AML it shows the highest rates of leukemia cutis. This leukemia cutis it may occur prior, busy, or even occur concomitantly with the diagnosis of systemic leukemia. In majority of the cases, it occurs with the presentation of the systemic leukemia. In this case, first the leukemia cutis came, and then we diagnosed it as acute myeloid leukemia. And there are some gene abnormalities which are associated with leukemia cutis, like numerical abnormalities of chromosome 8, translocation 821, and inversion 16. The exact pathophysiology is not known, but there is a role of the chemokine integration and other adhesion molecules which play a role in the skin-specific homing of T and B leukemic cells. The cutaneous manifestations, they are both specific and non-specific. Specific is leukemia cutis, and non-specific, they are inflammatory, paraneoplastic, or secondary to marrow failure. The clinical appearance, which is specific, is the present with erythematous to violaceous papules or nodules, which is most frequent as seen in this case. And these nodules, they're firm or rubbery in consistencies, and they can become purpuric if the patient is thrombocytopenic. And other unusual presentations are figurate erythemas, gutted psoriasis, stasis dermatitis, and ulcers. And there are even reports that leukemia cutis is localized only to the site of the infection, like herpetic lesions, any trauma, IV catheters, and recent surgeries. And non-specific cutaneous signs of leukemia are much more common, which account for 30 to 40%. And these are hemorrhagic, including petechiae, purpura, and erythemosis. And other reactive or paraneoplastic lesions include generalized pruritus, sweet syndrome, pyoderma gangrenosum, exfoliative dermatitis, urticaria, erythema multiforme, erythema nodosum, ichthyosis, and vasculitis. In this case, it is an acute myeloid leukemia, which is divided into 8 main subtypes. In that subtype, my present case is acute monocytic leukemia. In general studies, acute myelomonocytic leukemia and acute myelocytic monocytic leukemia, they have highest rates of skin involvement as seen in this case. And even the infiltration of gingiva, skin, or meninges is characteristic of monocytic subtype, which is seen in this case. After the cutaneous examination, any case detailed examination of the peripheral blood and bone marrow should be done to diagnose the specific subtype. And for the diagnosis of the acute myeloid leukemia, presence of greater than 20% myeloblasts in the bone or blood marrow should be present, which is seen in this case. Conclusion: leukemia cutis is important because it is a systemic manifestation of the underlying leukemia, and even it gives a clue that the patient may have additional sites of involvement, like extramedullary involvement, like meninges or CNS, which is the most common site of spread. And even it gives a clue for the prognosis because acute myeloid case without any skin involvement, there is a 6% survival rate. There is a decreased mortality, whereas in patients with acute myeloid leukemia with skin lesions, there is an increased mortality. Therefore, immediate and prompt diagnosis should be done, and appropriate treatment regimen should be started immediately. These are my references.
Next, thank you, Pravalika. Next speaker is Gupta Sneha, a case disease of Hailey-Hailey in 3 generations.
Good morning, everyone. My presentation is an interesting case report of Hailey-Hailey disease in 3 generations. The Hailey-Hailey disease, also known as benign familial chronic pemphigus, it is a rare autosomal dominant acantholytic disorder, and it is due to the mutation of ATP2C1 gene, encoding for calcium ATPase pump in the Golgi apparatus of epidermal cells, and due to these faulty calcium pumps, there is disorganized function of the desmoglins and there is breakage of the adhesions, and it commonly presents in the 3rd and 4th generations, and the presence with painful erosions, vesicopustules, and scaly erythematous plaques at the sites of friction such as neck, axilla, and groins perineum mainly. And the present case report has been is being reported to emphasize the positive family history in the Hailey-Hailey disease. And my case reports consists of a 45-year-old female patient, her 66-year-old mother, and 30-year-old daughter. And my case number 1 is the 45-year-old female patient who presented with recurrent itchy, fluid-filled lesions and erosions with malodor over neck, axilla, flexors of elbow and genital areas, with history of exacerbation during the summer months during the preceding 15 years. On clinical examination, there were multiple vesicles which ruptured to form erosions and maceration over the intertriginous areas. And the patient was admitted in a DVL ward, and skin biopsy was done to confirm the diagnosis and sent for histopathological examination, which revealed the features consistent with Hailey-Hailey disease, which is partial acantholysis and dilapidated brickwork appearance. And the patient was given prednisolone at 0.75 mg per kg, and simultaneously dapsone was initiated at 100 mg per day to prevent the rebound after stopping the oral corticosteroid. And the patient was also given oral broad spectrum antibiotics along with daily normal saline dressings. And the patient was treated with topical potent corticosteroid and antibiotic cream. In this case, mometasone with fusidic acid combination was given, and new vesicles stopped appearing 2 days after starting the treatment, and the lesions dried up with reepithelialization starting on the 7th day. And within 14 days, 70 to 80% of the lesions healed, leaving the post-inflammatory hyperpigmentation. And then oral steroid was tapered, and then dapsone was given till 6 weeks, and then tapered to 50 mg per day. And these are the pictures of the 45-year-old female with erosions over the both axillae and the groin areas, along with maceration. And her 66-year-old mother, who is case number 2, and 30-year-old daughter, who is case number 3, also had similar lesions of the flexures of axillary and inguinal regions, which showed remissions and exacerbations. And this benign familial pemphigus is a rare autosomal disorder characterized by recurrent blisters, erosions, and crusts in the intertriginous areas. And it is characterized by exacerbations and remissions with a good prognosis. And more than, this case report, in conclusion, case report has been done to emphasize the genetic association of Hailey-Hailey disease that has been manifested in 3 generations. And it is a benign disease with remissions and exacerbations and a good prognosis. And these are my references.
Thank you, Dr. Sneha.
Thank you.
We have now come to the end of the session. I thank our chairpersons and all the speakers for their active participation. Thank you so much.
Okay, thank you.
Thank you, ma'am.